guys ready to dive into blocks? Okay, does anyone have any questions on junctional before we start with blocks? No? Okay. All right, so let's talk a little bit about AV blocks, okay? How many of you guys have heard of AV blocks in some way? You've heard of them? Okay. Is there anybody who's like, okay, I really think that I kind of understand this a little bit? Okay, a little bit? That's okay. No, that's good. That's good. I'm happy to hear that. So I would say that AV blocks are one of those things that once you get it, there's like this light bulb that comes on and you're like, oh. But until you get to that point, it's really, really challenging to understand. So I'm going to give you a lot of different analogies. I really, really want you to ask questions, because if you don't really get it, then I want you to get it. So if I'm going too fast or anything like that, please let me know, and we'll talk about it, okay? So we're going to talk about the various kinds of blocks, and we're going to talk about what they mean clinically, and what we're going to do about them, and how you're going to be able to identify them, as well as how to differentiate them from one another, which can be challenging sometimes. So let's go back to our picture here, okay? So we've talked about rhythms that come from the top of the heart here. And what are those rhythms called that come from the top of the heart? Sinus rhythms, and then there's one other chunk too that usually come from over here somewhere. Atrial rhythms, right? Because they come from the atria. So those rhythms are like AFib, A-flutter, PACs, SVT, all that kind of stuff. So we've talked about that, okay? So that's what comes from the top of the heart. This is a good review anyway. What rhythms come from the middle of the heart? The junctional rhythms, and we have plain old junctional, accelerated junctional, and junctional tachycardia that can all come from the middle, right? Okay. What rhythms originate down here in the bottom of the heart? Ventricular rhythms, right? Because they start in the ventricle. So, so what are those ones? VTAC, VFib, idioventricular, and accelerated idioventricular, as well as PVCs. All start down there, okay? So we've pretty much talked about all of those, okay? So what we're looking at with blocks is, instead of them coming from a certain area of the heart, you actually have a problem on the electrical highway, okay? And I alluded to that a little bit when we were talking about junctional. So normally, my heart rate starts up in the SA node, and then it spreads through these little fingers here, through the atria, carries down this little pathway, goes through the gate of the AV node, carries down through the bundle of his, splits out to the right and left bundles, and then goes into the Purkinje fibers, right? We all know that that's kind of what happens, okay? What happens, here's our different kinds of blocks we're going to talk about. What happens is, when you've got a block, you have a problem somewhere in between here and here of stuff getting to the bottom, okay? So I'm going to talk about an analogy that really helped me understand this, okay? I live in Liberty. If I was going to drive to Olathe, what road would I take? I-35, right? I take I-35. It's like straight through. Except for when? Yeah. Except for during rush hour, right? Because during rush hour, that would be horrible, because I do not want to be on I-35 in Overland Park at 4:45 in the afternoon, right? Okay, so if you think about it that way, there's all sorts of different reasons why I would not take I-35, okay? If for some reason we had a big tornado and it went right down the Missouri River and cut out all of the bridges from the north of the river to south of the river, I would not be going south of the river, yes? Okay, that is one type of block. That would be like third-degree block. Nothing is getting from the top to the bottom, okay? However, if I let's say every morning I know that if I leave my house after 7:15, I'm going to have crazy traffic. You guys usually come to work at either 7 o'clock in the morning or 7 o'clock at night, except for the ED people, because you guys start at all sorts of weird times. But if you leave your house at the same time, it's pretty much the same amount of traffic every day. However, if you leave later or earlier in some cases, the traffic will be a little bit heavier, but it's still kind of at a predictable rate that it's going to be heavy, right? So if I leave my house after 7:15, there is no way that I can park in yellow, ride the shuttle, and get to my office by 8 o'clock. That is just not going to happen. But if I leave my house at 7:10, no problem, because at that time the traffic will flow right in. Okay? Does that make sense? That is another kind of block when we have slowing of the electrical impulse through here because of blocks in the highway. So when you think about that, just kind of think about that analogy, and that may help you. Okay? So there's a whole bunch of different kinds of blocks. So there's a first degree AV block, second degree type 1, also known as Winky block, which is the person. Okay? And there's a song for that one, so you'll remember that one. And then second degree Movitz type 2, which is also known as Movitz 2. Okay? So like we don't make it hard enough for people, we give people these nicknames of people's names. Because if they found it, they think they should be named after it. And then we're going to talk about third degree block, which is also called complete part block, but these are the same thing. Okay? Then we're going to talk about bundle branch blocks. How many of you guys have already seen a first degree block or a bundle branch block on your unit? Already seen it. Okay, those are extremely common, pretty benign, but then these kind of things, they kind of progress in severity. So we're going to talk about that a little bit. So it's really important when we go through, this is on, I think it's page 19 or 20 of your book. It's kind of towards the beginning, the steps to identifying the rhythm. Okay? So last week, when we did the homework, what a lot of you guys said is that, yeah, I just kind of eyeballed it. What page is that? 19? Oh, okay, so when we do the steps to identifying the rhythm, it's really important as we get into these more complicated rhythms to actually measure. Now, almost everything that was on the homework last week, you could kind of eyeball it and be like, yeah, I'm pretty sure that that's that. Now, that's fine. The problem is you can miss some really crucial pieces of information when you're eyeballing it. So we measure our strips at least once a shift, and then with any changes in clinical conditions. So you need to do that within 2 hours of assuming care of your patient. Okay? So what you're going to do is you're going to look at the rhythm, and what we mean by this is regular or irregular. Then we're going to look at the rate, and how do we calculate the rate? What did you say? R to R. R to R, and then 1,500 divided by the number of little boxes, right? Okay, and then what about if it's irregular? 6-second strip, count them up, and we're good to go, right? That's my favorite one because it's way easier. Or, what if you work on a unit that has a monitor anywhere? How are you going to calculate your rhythm? Or you can like look at the number and say, hey, look, their heart rate is 65. So that's perfectly acceptable too. On the test next week, you will have to calculate it manually, but I have yet to been in an experience where someone's like, can you calculate that manually for me? So just saying that, just throwing that out there. All right, so it is important to know what the rate is. And then we're going to look at the P wave. So now we know it's important to look at whether or not it's inverted, right? So that is one thing we're going to look at. And is it there? The next thing we're going to look at is the PR interval and the length of the PR interval, and then also how many boxes it is from the beginning of the P to the beginning of the R wave, and then also is it the same every time for every single complex. Then we're going to look at our QRS complex and look at the width of our QRS complex, and then we're going to look at the T waves. T waves are something that are a little bit more advanced, but we are going to talk about them a little bit, but I won't have you actually measuring the T waves or the amplitude or anything like that for the exam, so you don't have to worry about that. And then I'm going to look at the QT interval. So you remember when Janet showed the picture of the guy who went into torsades? Remember that? So he had a prolonged QT interval, okay? Prolonged QT interval plus a PVC equals torsades, or VTAC. So So that's not good. That's bad. So we really don't want that to happen. So that's really important to remember. And then we're going to look at any other components, patterns, random ectopic beats like PVCs or PACs. So we're going to look at all of those different things at the very end. So what I want you to do is from the beginning kind of start to say, okay, those are random ectopic beats. I'm going to cover those up and I'm going to come back to those at the end. That will help you a lot when you kind of go through some of this stuff. Okay, so let's start out by saying this is what normal sinus rhythm looks like. We all know that, right? So normal sinus rhythm. So when we talk about blocks, we're comparing it to normal sinus rhythm. So normal conduction of the heart, we kind of already talked about this. The SA node is 60 to 100, 40 to 60, and then 20 to 40 is down to the Purkinje fibers. So like I said, it's, we have AV blocks occur due to a jam in the normal flow of electricity. So what is the holdup? What causes these? There's a couple of different causes, and although I'm going to pop these causes up throughout our presentation, these are pretty much the causes for all of the blocks, okay? So if your patient is doing anything on this list, they're at risk for heart blocks, which means you need to pay attention, okay? Now, I think when you look at this list, you'll be like, yeah, but that's all of my patients. Yes, you need to pay attention, okay? So MI, anybody who has an MI, DIG toxicity, digoxin, root of all evil, that drug is. I mean, it's amazing for what it can do. However, it has a very, very narrow therapeutic window. So if you are outside of that therapeutic window, because you're dehydrated, because you're sick, because you have a fever, or whatever it may be, then you can go into a lethal block very easily, as well as VTAC and VFib and junctional. So very important to watch those patients that are on digoxin. Acute myocarditis, calcium channel blockers, beta blockers, and anyone who had heart surgery. Okay? So that's causes of temporary blocks. Now, permanent blocks, sometimes if MoDOT and KDOT did not take care of the road, that road would get potholes in it and it would have all sorts of issues all the time. And you know, for your little 85 or 90-year-old patient, their electrical pathways are full of potholes and they are tired, okay? So sometimes, just like they drive slow on the highway, they might drive slow through their electrical pathway as well. So that's not necessarily bad. It's just important to remember that sometimes just because of aging, those pathways may not work as well as they have in the past. Other things to think about are congenital abnormalities, and a lot of times you'll see that more in peds or the very, very young population, and that is kind of goes back to what we were talking about the valvular diseases. That's a little bit with that. An MI, and usually if they have an interoseptal MI, like we pretty much knocked that whole middle section out. So if that's the case, then they may be stuck with that block. Cardiomyopathy, because as the heart gets out and gets fat and floppy, those wires only stretch so long, and then when we pull them apart, sometimes those wires snap a little bit in the middle, and then it can't jump across. So if those wires snap, there's no way to get that electrical impulse apart across that divide. So if that's the case, then sometimes people who have cardiomyopathy, like anyone who's in heart failure, might possibly get blocks. And then again, cardiac surgery. It's important to remember in cardiac surgery that it's pretty brutal what they do in there, and they're jacking around in there with a scalpel. So these electrical pathways are microscopic. So it's not like we can visualize the pathway. So especially if they've had a valve surgery, they're highly likely to have some sort of a block. That's one of the major complications of cardiac surgery. So just kind of something to tuck away in the back of your mind. So again, heart rate times stroke volume equals cardiac output. So that's very important to remember as we talk about blocks, because we're going to be looking at what could be their stroke volume, what could be their heart rate, and how will that affect how they feel, meaning cardiac output. Now, who works in the ICU? Okay, so in the ICU, they have this beautiful monitor that tells you like a number, what the cardiac output is, okay? What about the rest of us? How do we assess cardiac output? Yeah, with our eyeballs, right? Good old-fashioned eyeballs. So we can look at them and we can say, yeah, you don't